All right, guys, we're going to go ahead and get started. Let me share my screen. All right, so like I said in my email, some of this may be disturbing to you, some of it may not. Some of it may be inappropriate for children to look at. It's just kind of the true hard facts here. We'll get through it and then we'll move on, okay? But if you do have questions, don't hesitate. Don't be embarrassed to email me and ask me, okay? I don't think a lot of your NCLEX is going to be on this part, but you never know. So, but if you do have questions and if you don't understand something, I won't think anything different, okay? So the concept of sexuality, okay? Um, it contributes to healthy relationships. It gives you a sense of well-being. It's definitely individual and highly personal, meaning that it kind of evolves around life experiences and definitely influenced by psychological, physiological, religious, cultural. So there's no normal, universal sexual behaviors, okay? So it begins at conception and continues through your lifespan. And as a nurse, you must consider sexuality in the larger context of the development of the individual that you're caring for. So we'll talk about some family planning, menopause, menstrual dysfunction, sexual dysfunction, and sexually transmitted infections. So development, just real quick here, several months after birth, babies find their fingers and toes and their genitals. The touch begins pleasurable sensation, but not a sexual experience, okay? By the age of 3, more purposeful kind of a masturbation. You can see little boys that will play with themselves, little girls that will touch themselves to make, because it feels good, so they do it, okay? They don't know they shouldn't be doing that. They may have orgasmic responses, and boys do not ejaculate at 3. So when we get to about the 9 or 10, that's when the physical changes of puberty begin. So breast buds and pubic hair, we call these Tanner stages, and these are by physical growth, okay? Sexual maturity is rated on those Tanner stages. And you'll have the adrenal glands will start to produce testosterone and estrogen, and we'll talk about that. So usually about 9 or 10, you'll start seeing breast buds and pubic hair. And when they go in for their physicals for school, the doctor or the nurse practitioner will examine them, just glance, make sure everything is okay, and then they'll document what stage they're in. So like I said, females are going to start to produce estrogen. Theolarchy is the breast buds begin. Girls will get their broadening of their pelvis and their hips, continuing on growing hair growth, pubic hair. They'll start to have some axillary sweatings. Oh, good time to introduce the deodorant to them. Their vaginal secretions become milky, so change from an acid to alkaline. So they may have a little bit of discharge, so you'll have to talk to them about that. And then menarche, which is their first menses, usually within the 2 years of that start of that breast and pubic hair changes. They will have some tenderness of their breast and possibly adolescent or water retention. Some water retention and tenderness of the breast will usually begin. Now, males, they'll produce progesterone. Progesterone, so in their testes and their scrotum will increase in size. The skin that covers their scrotum, it'll be getting darker in color. Pubic hair for them will continue. Axillary sweating begins. Nocturnal emissions, some people call those wet dreams. They'll start to have that. Their voices will crackle and change. They'll have dramatic growth in height, like 6 inches sometimes. You'll say, why don't their clothes fit from last summer? And mature about 2 years later than girls. All right. So, and then in young adulthood, you'll start to have some formation of, sexual experimentation. So we have to give them information. This is occurring earlier than previous decades. So provide factual, non-judgmental information for these young adults. They're forming intimate relationships with long-term implications. So young adults are often concerned about the normal sexual response. Communication needs to be important. And in that middle adulthood, you're going to have decreased hormone production, and we'll talk about that. Okay. So some more development. Perimenopause is a period of hormonal change during which the body gradually makes the transition towards permanent infertility. Menopause is the cessation of menses, so menses is over. Remain capable of multiple organisms, this should be orgasms. May experience an increased sexual desire after menopause. Vaginal lubrication, elasticity decrease with menopause. Phases of sexual response cycle may take longer. More time needed to achieve erection and ejaculation. More direct genital stimulation is required to achieve this. Erection may be less firm. Volume may be decreased of the ejaculate. Intensity of contractions with orgasm may decrease, and longer time before the next erection and erectile dysfunction is more common. All right, so sounds like when you get older, nothing works as good as it did before, just like with everything else, right? So sexual health is components. Some components of sexual health are sexual self-concept, a person's body image, their gender identity, gender expression, and freedoms and responsibilities. So the World Health Organization definition is physical, emotional, and mental. So social well-being in relation to sexuality. So it has to be a positive, respectful approach to sexuality and sexual relationships, possibility of pleasurable, safe sexual experiences, and respect, protection, fulfillment of sexual rights of all individuals. Sexual rights, you have right to sexual freedom, right to sexual autonomy, integrity, privacy, and equity, the right to reproductive health services, the right to sexual education, and the right to make free, responsible reproductive choices. As I had said earlier, it is cultural considerations. You have cultures, you have religions, and you have personal expectations and ethics. Okay, so your culture can be related to some degree of like how you dress, rules about marriage, expectations of your role behavior, like does the man do this, does the female do this, and some social responsibilities. Also some sex practices, attitudes towards various aspects of the human body, weight as a culture determinant of attractiveness, like, you know, culturally, if you see, like, as an example, you know, you see those heavier full-size women that are dancing like on TikToks or on YouTube, and you get all these people that have all these nasty grams and send them all that stuff. So in our culture, you know, it's not supposed to be attractive to be big. And then how they dress and nudity, attitudes towards that. And then they have controversial sexual attitudes and practices like female circumcision, male circumcision. So nurses must not project your own cultural beliefs and preferences on others. Okay, so you can't push that on anybody else. Religion, it's a guideline for what's acceptable. Prohibited sexual behaviors, you know, you're not, an example in Catholics, you're not supposed to have sexual relationships before you're married, okay? And then there can be consequences for that. So it can be detailed and rigid, right? Or it can be broad and flexible. It may conflict with the values of the largest society. can create anxiety and sexual dysfunction in some people and can create conflict within families. And then with personal expectations and ethics, that comes from cultural norms, and couples need to explore and communicate clearly about their sexual expression. All right, sexuality and gender. Sexual orientation is a person's attraction to people of the same sex, the other sex, or both sexes. Um, it's a continuum with a wide range between extremes. You can be exclusively heterosexual and exclusively homosexual. Bisexual is attracted to individuals of both genders. The origins of sexual orientation are not really understood. Some people say that you're born that way. Some people say that it's psychological. And some people say it's genetics and environment. It's your personal preference on what you think it is. So a person's sexual orientation is enduring, unlikely to change over a lifetime. Many people may be uncomfortable disclosing their sexual orientation. Some people are not. Increased for risk disparities in health access and an increased risk for certain health conditions and behaviors will come along with that when you disclose your sexual orientation. All right, so there are some varieties of sexualities. So transgender, transsexual, gender dysphoria, and these are erotic preferences and sexual lifestyles. So we'll talk a little bit about the transgender first. So transgender are gender identity and or expression different from gender assigned at birth. Transsexual are people who have changed or seek to change their sexual anatomy with medical interventions. And gender dysphoria is a strong, persistent feeling of discomfort with the assigned gender. So not all transgender individuals experience distress, okay? So not all of them do, but it is increased risk to physical and emotional safety with all of these, okay? So erotic preferences and sexual lifestyle. So talk about masturbation and mutual masturbation. So it is self-stimulation of genitals for sexual pleasure. It's a way to discover erotic feelings, learn about sexual response. Mutual masturbation, that's when you're sharing it with a partner, okay? Oral genital sex, use of mouth to stimulate your partner's genitals. There's 3 different versions of that. There's something called the cunnilingus, fellatio, and I'm sure you all have heard of the 69 position. You're not going to be asked a test on that, I promise. Test question. And then you have anal stimulation. You have genital intercourse, that's where penile and vaginal intercourse. They also have anal intercourse and anal stimulation. Yes, that's with the anus. And other varieties of sexuality. We could go on, and we're not. Okay. All right. So sexual response cycle. Its cycle starts in the brain. Okay. Regardless of sexual orientation, there is a motive for sexual activity. So it starts in the brain. It's by an image, or it's real erotic stimuli. It involves arousal, right? So you have 4 phases. Okay. So the 4 phases you may need to know, okay? The 4 phases identified by Masters and Johnson of sexual response is the excitement phase. That's the vasocongestion, myotonia. Then you have the plateau stage, which is the strong, prolonged sexual arousal. Then you have the orgasm stage, which is involuntary climax of sexual tension and release. And then you have the resolution stage, which is return to unaroused state. So you probably need to know the excitement stage, the plateau stage, the orgasm stage, and the resolution stage. All right, so alterations in sexual function. This is the ability to engage in sexual behavior and is important to most people. Transient problems with ability to respond to sexual stimulation, maybe a generalized to all sexual interactions and settings, maybe situational. Past and current factors are generally involved. So they take a variety of forms, and some may have genetic components. You may have some social cultural factors, psychological and cognitive factors that that alter your sexual function. All right, so before we move on, let's go over some social cultural factors. Okay, so restrictive upbringing plus inadequate sex education, that could be an alteration. Rigid gender expression, okay. Sex only for procreation, not pleasure. These are things that are social cultural factors that could have alterations in sexual function. Parental punishment for developmentally abnormal exploration of genitals or childhood sex play. So that's yelling and screaming at your teenage boy for masturbating in their bedroom. Okay. You have to set limits. We can do it here. We can't do it here. This is, you have to set limits. Okay. And the pressures of family and work. So that could be some alterations. Some psychological factors could be negative feelings that interfere with the ability to experience some pleasure and joy. Guilt from enjoyment of sex or participation in sexual activities, like, oh, this is wrong, we shouldn't be doing this. Anxiety related to prior sexual abuse, so you have to be careful with that. Patients that have had sexual abuse have a hard time having normal sexual functions again. Fears of pregnancy, STIs, could be painful. The actual sex part of it, the intercourse, or the fear of vulnerability and intimacy. And some cognitive factors, you can have internalization of negative expectations. So you're internalizing negative expectations and beliefs, not having accepted your own sexual orientation or gender identity. And you can have relationship problems, right? Conflict or anger, loss of physical attraction to the partner you're with, attraction to someone else, failure to communicate, and disagreements about sexual frequency and activities. All right, now moving on to alterations and manifestations. So physical health alterations can interfere with sexuality. So those can be like chronic conditions, can be surgery, spinal cord injuries, disfiguring surgeries, or accidents. Something that comes to mind with me is mastectomies, right? With breast cancer survivors, when they've had a mastectomy, disfiguring surgeries, and STIs. And then you can have prescription medications that may have side effects that alter sexual function, but you need those prescriptions. So those are some alterations. And then you can have specific alterations in sexual function, like sexual desire disorder, sexual arousal disorder. I talked about pain, sexual pain disorder, and orgasmic disorders. So there's a lot of alterations you can have. So with this, let's talk about this dissatisfaction problems. So that's kind of when your individual experiences sexual desire and arousal, but the orgasm is still dissatisfied with the sexual relationship. So they're having the desire, the arousal, they're reaching the climax area, but they're still dissatisfied. More often related to problems in the relationship than physical response. Okay, so if they're having the desire, the arousal, and the orgasm, then they're physically still getting sexually satisfied, but mentally, cognitively, they're not, because there's more problems than just physical, right? There's a lot of psychological. Can be more disturbing than any other type of sexual dysfunction. This is the dissatisfaction problem. And these are sometimes situational, like times of stress, illness, personal environmental trauma, the inability to communicate effectively. I know if you watch some shows on intimacy and relationships, they'll tell you you need to tell your partner what you want, what feels good, what doesn't. And if you can't communicate that, that could be a problem. You could have unresolved conflict, rigid, unequal power and gender expressions, right? I'm always doing the dishes, I'm always cooking, I'm always cleaning, I'm always mopping, I'm always vacuuming, I'm always doing the laundry, right? You don't find me attractive anymore. So I'm sure you've heard that, maybe not you, but you know, on TV or something. And lack of intimacy or lack of feeling connected, right? You need to feel connected to your partner before you have sexual intercourse. All right, moving on. So we need to talk about health promotion with them, right? To get them um, feeling better about themselves. So we can do a healthy lifestyle. We can do cancer screenings. We can do vaccinations against HPV, right? Cancer screenings for prostate cancer. Women, we want to promote cervical cancer, mammograms over 40, and healthy lifestyle. You know, sometimes the risk it'll reduce if you're not sick, or if your medications, you don't need those medications anymore, okay, for like high blood pressure or something. And then we need to talk about safer sex practice with them. You know, it has to be mutual. No unprotected sex, especially if the HIV or partner's status is unknown. HIV testing when entering into a new relationship. I know people that do that, right? Hi, my name's Bill, and this is, you know, this is what I require. So latex condoms for any type of intercourse, oral, vaginal, anal. Lubricate the condoms with spermicide. Practice less potentially damage to sensitive tissues, right? So mutual masturbation, avoiding anal or oral sex, don't damage sensitive tissues. No drugs, no alcohol, because then you're not compliant, right? You're not saying in your right mind that you want to do that. No sharing of needles, no sharing of toothbrushes or sex toys, and no unprotected sexual activity if one partner is HIV positive. And if you are HIV positive, a woman can take steps to prevent pregnancy. All right. Okay, moving on here. So the nursing assessment, we have to do the patient interview, the physical exam, the diagnostic testing, independent interventions. We have to talk about inappropriate behavior. We have to learn to recognize sexual abuse. And then we can talk about some collaborative therapies. So they can have surgery, pharmacological therapy, and non-pharmacological therapy. So when you're interviewing, you definitely want to know the timing and the description of the problem, any medications that they've tried, any past medical history like chronic diseases, past illnesses, any surgeries of the penis or prostate, other surgeries, and this is all for men. The psychosocial history like tobacco, alcohol, drugs, sexual history, including any STIs that you had, and lifestyle and stressors. When you're interviewing women, you definitely need the same timing, symptoms, medications that you've tried. Definitely need to know when their last menstrual cycle was, any chronic illnesses or surgery, their menstrual history, their OB history, any family history of cancer. And you want to know if they've done tobacco, alcohol, and drugs, talk about their sexual history, STIs, and find out if they are on any birth control. Okay. So the physical assessment, you have to approach it to reduce the patient's anxiety. So you can't be giggling, you know. It has to be non-judgmental. You have to be empathetic. You have to be gentle. Use caution to avoid misconceptions of sexual harassment or abuse. Touch in non-intimate fashion. Obtain your patient's consent before performing any procedure. Explain what you're going to do before you start it, and have another healthcare worker in the room. So diagnostic testing, we can do a CBC, UA, we can do a sperm analysis, culture and sensitivity. We can do hormone levels, because what we talk about in the beginning, hormone levels, right? Hormones, estrogen and progesterone. And we can do prostate specific antigen. Remember back to PSA, to hypertrophy, but pH. Okay. Image testing, we can do ultrasound, CTs, laparoscopies, and we can do biopsies of breasts or genitals. We can do the same thing with the male or the females, but we can do a pap test with the females. We can also do a histoscopy, which is an exam of the uterus. We can do a mammogram, and also, again, biopsy of breasts and genitals. We can do collaborative therapies. We can do surgery, pharmacological therapy, and non-pharmacological therapy. Let's talk about patient education. So your patient education has to be age and development related, stages in human sexual response, information about some birth control if they need that. We can definitely talk to them about safer sex practices. Talk to them about STIs and how to prevent the transmission. Show them how to do a breast or testicular exam. When can they have sexual activity after their illness or their event that you're talking to them about? How some medications or conditions may affect their sexual function. Give them education on all those diagnostics, medical and surgery procedures. Adaptations that will allow patients with physical impairment to resume or continue sexual activity, and referrals to appropriate community resources as needed. Those are some independent interventions that you can do for patient education as a nurse, seeing patients that are having sexual function problems. All right. Also, you may have to deal with some inappropriate sexual behavior from your patients, right? Nurses seem to encounter sexual inappropriate behaviors on the job. Sometimes it can be aggressive, or it can be just joking, non-aggressive. But either way, you have to implement nursing interventions with such patients. Determine whether the behavior is an attempt to communicate a physical need. If the behavior is truly inappropriate, communicate that behavior. Is that not acceptable? Yes, you cannot touch me in the bottom. No, you cannot. Whatever, right? You can't touch me where you want to touch me. Tell the patient how the behavior makes you feel. That makes me feel uncomfortable. Identify the behavior you expect. When I'm coming to change your IV, I expect you to keep your hands to yourself. Set firm limits. Be assertive. Try to refocus the patient to the real concerns and fears. Report the incident to a nursing instructor, your charge nurse, clinical nurse specialist, and clarify the consequences of continued inappropriate behavior to that patient. Okay. Recognizing sexual abuse is a lot harder sometimes, but nurses are mandated reporters. Remember that. Required by law to report all instances of suspected child maltreatment, and mandatory requirements for adults vary state by state. Okay, so if you have a patient that comes in and that has been raped, it is not your mandated part to report that. That is for the patient if they are over the age of 18. Okay, so if they are not over the age of 18, it gets a little sticky. But if they are over the age of 18, the best thing for you to do is to call the Center for Abuse in Peoria, and they can set them up with help if they want it. If they don't, they can still come and talk to them about it. But as a nurse, you do not report sexual abuse of an adult, okay? Unless, make it more complicated, unless it is an elderly patient, okay? And we will get more into those specific ages and stuff when we talk a little bit about that next semester. But if they're under the age of 18, you're a mandated reporter of child maltreatment. If they are over the age of 18 and not considered an elderly patient, then you are not going to call them. You're going to give the patient the number for the Center for Prevention of Abuse. And if you're in Peoria, they do other counties too. But if you're going to give it to them, and then they're going to have a counselor come out, and the counselor will talk to them and say, you know, these are your rights. These are what we can help you with. But if the patient is an elderly person and living in a home, or they're being abused by a caretaker, and you know this, then yes, you have to mandate your mandated reporter. It gets confusing, but we'll go more into it next semester, okay? Just know that with children, you definitely need to respond, and you need to report it in with elderly, okay? Some sexual abuse signals. Children will have some behavioral signals, avoidance of physical contact. They may have some depression or post-traumatic stress. They may do some self-harm or have suicidal behaviors. They sometimes have difficulties in school. Sometimes these are the kids that run away from home or school a lot. They'll have some changes in their hygiene, regressive behaviors, inappropriate knowledge of sexual topics and behaviors. So you'll see those. And sometimes you'll see a lot of that stuff with the adults too. They'll have depression, anxiety, PTSD. They'll do some self-harm, fear of contact of that person, and disruption in personal relationships, and a strong aversion to consensual sexuality activity too, because if you're being abused, then you don't want to engage in it, because all you do is think about how the abuse has affected you. Okay. All right. Now, collaborative therapies. So, surgeries that affect sexuality. So, they can have surgery for prostate cancer that may result in erectile dysfunction. Ovarian cancer may result in early menopause. Spinal surgery may impede sexual function, and bowel surgery may lead to dysfunctional body images, okay? So you probably need to know the surgeries that could affect sexuality. That's prostate cancer surgery, ovarian cancer surgery, any spinal surgery, or bowel surgery. Surgeries that treat alterations can be in men. You can have erectile dysfunction. They'll implant a prosthetic device. We'll talk about that today. Reconstructing penile arteries. Well, that sounds like a fun surgery. And blocking veins that drain the blood from the penis. We can talk about that later. Removal for women, they can do removal of tissue around the vaginal opening for relief if they're having pain, and sexual reassignment surgery. Some pharmacological therapies we can do hormonal contraceptives, we can do female infertility medications, and males and females can do hormone replacement therapies to help maintain those hormone levels, and sometimes used to treat of cancer. And non-pharmacological, we can do mechanical or assistive devices. We'll talk about this later. Vacuum pumps for men, vibrators to increase women's sensations, a harness or wedge to position to help with spinal cord injuries. Nurses should assure patients that there's nothing wrong with such aids, right? Psychological relationship counseling, one-on-one counseling, couples counseling, mindfulness techniques, and integrated sex therapy. So we can do some medical, behavior, cognitive treatments, and customize it to the patient's particular problem. All right. So lifespan considerations. Infants and children, you know, the child doesn't understand the difference between a male and a female, you know, for the first 12 to 18 months of their life. So assignment of gender to child affects how others interact with the child. It differentiates between the self and others, identify as male or female. Self-image is usually shaped by external beliefs, expectations, and attitudes of the family. And they're learning more about their bodies, right? They're including their genitals. They're going to identify of their own, they're going to get their identification of their own gender by what they see. Early awareness of differences between males and females, about 1 to 3 years old. So they're going to know that mom has breasts and dad doesn't, or mom has a vagina and dad has a penis, and they're going to ask questions. Between the ages of 4 and 5, they're going to get a fuller sense of their self and explore other body parts as well as their own. Between 8 or 9, become concerned about specific sex behaviors. They may approach parents with concern about sexuality. This is kind of sometimes when they say, where do babies come from? Because this is the age where they're going to school and they're learning and talking to other people, other students, right? Other kids. So the family role is very shaping of their patient or the child's view of sex and sexuality. So you really develop your gender identity, your body image, self-concept within the family, how the relationship is within your family. Parents' reactions to the questions about genital exploration can affect child's sexuality into their adult years. You know, like I always remember a mother telling her child, her male child, masturbation is wrong and you're going to go to hell. So then when he got married, he didn't have sex with his wife because he thought if anybody touched it there, he would go, you know, to hell. So that poor child, now he's a male adult, but we saw him one time in the office and he was just ruined for life. He had a hard time. Important for parents to answer questions honestly, use the correct names, right? My poor kids, I have 2 teenage boys at home right now, 17 and 16. And when I've been putting all these slides together, they walk by, they're like, Mom, we're so tired of seeing penises on your computer, right? But we use the correct names here. We talk about safe sex here. It's a very open thing because if you want them to talk to you about it, you have to be open with them and not make it such a big deal about it. I'll tell you a story about condoms when we get to that point. But it's what your kids are seeing at home and how they're going to react. Okay. So it's important for the nurse to provide parents and the kids opportunities to express concerns and ask questions. Encourage parents to discuss basic information with children, right? I was a teenage mom and I got pregnant at 17. And I always tell the story in class, but I'll have to tell it now. I got pregnant at 17 and my mom was pretty open with me and told me, you know, where babies come from and how, you know, the egg and the sperm got together and, you know, this is what develops. The bad thing is she really, really forgot to tell me how that happens. She just said everything came together. Well, she forgot to tell me how that happened. So yeah, I got pregnant at 17. And honestly, I can say that because I just assumed that's what she told me. And, you know, I was kind of dumb at 17. So I was just like, okay. So be careful how you discuss things because you have to be sometimes blunt, but appropriate, right? So in adolescence, 12 to 18, they've got some dramatic changes in the relationship to sex. They're fertile, right? They're becoming fertile. Relationships are interested. Peer groups are important. So nurses' approach should be guided by the teen's social development and cognitive development. Remember, non-judgmental, focus on the adolescent, not the problem. Ask parents to leave the room for part of that history when you're asking them. Assure the patient that everything discussed with the nurse is confidential, right? You can't go back and tell mom that I just had sex. Nurses may need to start conversations about sex and sexual organs if the mothers or fathers have not. Use specific language, the words the adolescent understands, and ask the teen what they know, because they may know only from what some other kid may know, and that kid may have been told wrong. Okay, so the physical exam on the adolescents is the same as the adult, but you have to do that Tanner staging. Pelvic exam on teens is only done when necessary due to a problem. So not every teen girl coming in is going to get a pap smear or a pelvic exam. And if they do, they have to have a chaperone present. Education about this to teens, you need to talk to them about their bodies being changed. Usually schools will do that with the health department, or they'll have you sign a paper or a waiver having somebody come in and talk to you about sex ed. You need to talk to them about contraceptives, STIs, and discuss the importance of healthy dating relationships. Don't let them get into an unhealthy relationship, and look for signs for dating violence, right? Like possible perpetrators, bruises, where the child can't go see other friends because they have to be with the boyfriend all the time. So look for stuff like that. Young adults, about 18 to 40, usually their sexual identity is fully established by 20s, no more experimentation. Majority engage in regular sexual activity. Reproductive health issues most common in the healthcare is sexuality related issues in healthcare, is information about pregnancy prevention, education about prevention and treatment of STIs, and referral to further medical psychological care for sexually compulsive behaviors. So those reproductive health issues most common sexually related issues in healthcare are information about pregnancy prevention, education about prevention of STIs, and referral to further medical psychological care for sexually compulsive behaviors. We have to talk about pregnant women. Sexual activity is usually safe for them and the fetus. It may not be safe if there's vaginal bleeding or amniotic fluid leaking. If the cervix is dilated or incompetent, patient has partial or total placenta previa, has a history of miscarriage, preterm or premature birth, and is carrying multiple fetuses, it may not be safe, but normally it is. Patient may report low desire during pregnancy. They may find it uncomfortable. You can suggest different positions, alternative activities. And postpartum, try to avoid vaginal sex for at least 6 weeks. Physical and your hormone changes may make sex uncomfortable. Middle-aged patient, that's usually between 40 and 65. So this is when everything is declining. Alterations in sexual function will happen. So women usually will have menopause. Men will more gradually and less dramatic have their climatic experiences lessen. Psychological or psychosocial changes, those may be a new role, the end of a career, children are leaving home, and may just be difficult to adjust to the differences. And last but not least, the older adults. So their interest in sexual activity continues. It's not when you hit a certain age, you're done. They may define sexuality more broadly. Women, vaginal secretions diminish and the vaginal walls thin and the breast atrophy. You can have difficulty in penetration. And in the men, they have fewer sperm, longer time to achieve erection and ejaculation, and they may have chronic pain, osteoarthritis, cardiovascular disease, and diabetes negatively can affect your sexual activity. So they will benefit from teaching related to sex, but may be reluctant to raise the topic. Also, with those elderly patients, we still need to talk about if they have any STIs and how to, like, grandma and grandpa in the nursing home or at the residential home, we still have to talk to them. They may not be able to be pregnant, but they can still pass STDs and STIs around, okay? All right, so I'm going to put this on pause for just a second. I'm going to take a few second break and then I'll be right back. All right, family planning. So contraception is a decision about contraception. We're going to talk about factors that influence the choice, and different methods may be appropriate at different times. What do we need contraception for? To avoid pregnancy, to gain control over the number of children conceived, right? Should be voluntary, right? Advantages, disadvantages, and effectiveness of it, and the factors that influence our choices. Once again, cultural practices, religious, cost effectiveness, attitudes, personal preferences. All right, so the first step in the process of contraception is decision to have a child. So decide about the timing of the pregnancy, okay? Maybe part of discussions when you first start dating, maybe decided later. Involves consideration of both parents' goals, relationship expectations, desire to be a parent. Do you want to be a parent? Do you not want to be a parent? Is it irrelevant if the couple's religious beliefs do not support contraception? So these couples, we need to talk about timing of the pregnancy. Preconception health measures, do we need to stop smoking? Do we need to stop drinking alcohol, caffeine? Do we need to discuss about over-the-counter prescriptions? Attaining the best possible health state before you conceive a baby. Where do you work, right? Maybe there's hazards at work or in the community. Do you work by radiation? Do you work in a chemical exposure place? So we have to talk about those. Physical examination, both partners need to be physically prepared. Genetic counseling if the family has history, if there's any history. And dental work the woman needs should be done before conception, because you did learn that when you are pregnant, the baby takes all your calcium from your teeth, and it ends up that your teeth will fall out if you're not healthy before. The nutrition for the woman should be average weight, average height. Underweight women should try to gain weight. Overweight women should try to lose weight, right? But not when you're pregnant. You're right. You want to do this before. This is all preconception. Remember, preconception. You want to take folic acid supplementation. When I do this in class, I always talk about always start taking your folic acid. If you're going out drinking to the club or the bars or anything, take that folic acid with you, because that's sometimes when things happen and those babies come, and everybody should be on folic acid no matter what. So if you're in that age and you're not using any contraception, take your folic acid, okay? Because it can affect your baby. If you do not have a high enough folic acid, then you'll have neural tubes defects, and we'll talk about that when we get into more of, I think you guys get that in part of your neuro stuff, okay? But yeah, folic acid. I told you I breed dogs. Right before I do my breeding with my dogs, I start giving them folic acid. So if you plan to have a baby, take some folic acid. Nurses should assess the cultural norms related to nutritional intake. So watch your culture on their intake and what they're eating and what they're not eating. Nutrition, and I just kind of said that. So establish regular exercises before attempting conception. Should be continued during pregnancy. So if you're already working out before you get pregnant, continue. It should not affect you at all. Don't start your Weight Watchers or your, 360 diet plan once you find out you're pregnant. And women should need to be up to date prior to their pregnancy. Any immunizations needed to be finished 3 months before. Influenza vaccination can be given during the flu season. There's a lot to do before you get pregnant. Okay. Now, if you have infertility, that is the lack of conception despite unprotected unprotected sexual intercourse for at least 12 months, okay? Infertility is the lack of conception despite unprotected sex for at least 12 months. I just said that, right? Profound emotional, psychological, and economic impacts. Sterility is an absolute factor, prevents reproduction. Subfertility is difficulty conceiving because both partners have reduced fertility. Secondary infertility is the inability to conceive after one or more successful pregnancies. So referral for infertility evaluation if unable to conceive after 1 year, more than 1 year of attempts. Earlier if couple has positive history of fertility lowering disease, and earlier when the woman is over the age of 35. And so those are just some terms that you may need to know. So infertility in women, it's necessary. These are the elements that are necessary for normal fertility, okay? You have to have, the female partner has to have a favorable cervical mucus. It has to have a clear passageway between the cervix and the tubes. Has to have patent fallopian tubes with normal motility. Ovaries must produce, so they're releasing eggs. No obstruction between the ovary and tubes, and endometrial preparation. Okay, so those are what women need to have. The male partner needs to have normal semen analysis done, unobstructed genital tract, a normal genital tract secretions, and ejaculate deposited at the cervix. So some genetics we call that we can see, right? The zygote has 47 chromosomes, and sometimes the baby will have a defect or genetic disease. So parents experience grief, fear, angry, and guilt, like we did this. Abnormalities may be evident at birth. Some of them will not appear for some times. The baby can have inherited disorders from one or both parents. And the nurse should anticipate parents' questions and concerns. So this is why they must have the basic knowledge of genetics and genetic counseling. And I always say this too in class. When I breed my dogs, I have to do genetics on my dogs, on the 2 dogs that I breed together. So I always think that people should have genetic testing. I wish it was just like a thing you had to do, but you don't. So, but it's good. It's good to do it if you especially have any history. So this is trisomies. Okay, so with, you'll all remember back to all the body cells contain 46, the sperm and egg contain 23, so you have 23 pairs of chromosomes, 22 autosomes. The woman has 46 XX chromosomes, the normal man has 46 XY, and so things can go astray, okay? So trisomies have 3 copies of a particular chromosome. So a zygote has 47. Most of these are fatal. Down syndrome has 21. This is the most common trisomy. Trisomy 18 is called Edwards syndrome, and trisomy 13 is called Pate syndrome. All have extremely poor prognosis. Monosomies, you'll see children with Turner syndrome. These are survive our chromosome mosaics. They're infertile. They will survive. Okay, and mosaicisms have 2 or more different cell lines. Trisomy in some, but not in all body cells. And these are less severe manifestations. We're not going to get too much into genetics, so here's just some basic stuff. The abnormality of the chromosome structure involves part of a chromosome, and its translocation is the abnormal rearrangement, and the deletions or additions, okay? Clinical may be mild or severe. Some are sex chromosomes. And I said in female, 1 of 2 normal X chromosomes is inactive, and we talked about Turner syndrome. In males, only one X chromosome. Most common is the Klinefelter syndrome. And when your maternal age is greater than 35 years old, your slightly increases your risk. Modes of single gene inheritance are your most common. Autosomal dominant, autosomal recessive. You'll have X-linked recessive is less common. X-linked dominant and fragile X syndrome. So you'll see all of those. Those are the X-linked dominant and fragile X are less common. All right. And now let's talk about fertility awareness methods. We're not going to go too much more into genetics. You'll get a little more genetics with ped stuff. Okay. So natural family planning. You can do natural family planning. That's the requires understanding of your ovulation cycle. You can do calendar rhythm, basal temperature, billing ovulation method, and simple thermal method. So natural family planning, you have to know your ovulation cycle, requires periods of abstinence, recording of events during your cycle. The benefits, it's free, it's safe, it's acceptable. It's some people whose religions, it prohibits other methods that they use this. Provides increased awareness of your body, no artificial substances, encourages couples to communicate. It's useful and to help plan a pregnancy. The drawbacks, it's extensive initial counseling to be effective, requires careful maintenance of your records, and difficult or impossible for women with irregular cycles. The calendar rhythm, that's when the woman records her menstrual cycle for 6 months to identify her shortest and longer cycles and her fertile and infertile phases. You have to have abstinence from intercourse during the fertile phase, and it's the least reliable fertility awareness. Okay. BBT, basal body temperature, that's when the woman takes on awakening before any activity. You have to use a basal body temperature thermometer, record on a graph to predict ovulation. It's based on the temperature. Sometimes it drops before ovulation, almost always rises and remains elevated after ovulation. So women who have intercourse just before the rise, they're at risk for pregnancy. The billing ovulation, that's the cervical mucus method. You have to have assessment of your mucus during those cycles. Mucus at the time of ovulation is clearer, more stretchable, more permeable to sperm, and can prolong sperm life. So you have to have a fern pattern when dried on a glass slide. Mucus in the luteal phase is thick and sticky, forms networks that traps your sperm, impeding passage. So abstinence from intercourse from when mucus starts becoming clear and more elastic until 4 days after the last wet mucus. Can be used with women who have irregular cycles because you're just using your cervical mucus changes. And the sympothermal method, this is cycle days. You have to have various assessments. You have to have cervical mucus changes, secondary signs. You'll have increased libido. You'll have increased mucus, cervical mucus. Couple learns to recognize the signs of ovulation, and you can do this approach with the FAB. So abstinence is the not having any sexual relations. This is the most effective. Coitus interruptus, this is that withdrawal before the man ejaculates. This is the least reliable. Inducing after intercourse is ineffective. It may actually push sperm farther up the canal. All right, so we can use spermicides. There's like 6 different types of spermicides. There's film, foam, a sponge, creams and gels, suppositories, and jelly. Okay, so destroys sperm by disrupting their cell membranes. Minimally effective when used alone. You probably need to use it with something else. Unfortunately, it may irritate your skin. It does not offer protection against STIs, and it may increase the woman's risk of HIV infection because it irritates the vaginal tissue. All right, barrier methods, male condoms. Viable when used consistently and properly. It is applied to the erect penis. Water-soluble lubricant should be used if condom or vagina is dry. So care important in removing condom after intercourse. It is effectiveness, but it is determined by how it's used. They're small, they're disposable, they're inexpensive. They're made of latex, polyurethane, and they have some that are all natural. The disadvantages is sometimes they break, sometimes displacement, tissue irritation, and dulled sensation, or they should not be stored in hot conditions. So you can't leave them in the car forever. So my quick story here about my boys. I have 3 boys. My oldest is 22 and he's out of the house, but he had this story too. So I have 22, 17, and 16, almost 16. He'll be 16 soon, next month. So when they leave the house and they're in the car and we go to a baseball game or we go to a dog show or we go wherever we're going, I have their full undivided attention when you're going down the highway at 70 miles an hour. So that's when I always started to talk to them about safe sex and all that stuff, and they couldn't jump out of the car, or at least I hope they didn't jump out of the car when we were going down the highway at 70. But we would talk about that, and the boys always knew, they could talk to me about things. And well, then I got a granddaughter, and she would ride in the car with us a lot, and so we really couldn't talk about that stuff because she was a lot younger at the time. So we decided that we were going to talk to we were going to call condoms our seatbelts. So it's always been a kind of a joke now when the boys leave the house, I tell them, make sure you put your seatbelt on. And they know that what I'm talking about. I'm not telling them to go out and have sex, but I'm telling them if you're leaving the house and whatever you're doing when I'm not with you, I need you to make sure that you have your seatbelt on. And so they kind of giggle all the time. Yes, mom, I'm going to put my seatbelt on. And my granddaughter has no idea what we're talking about. She just thinks we're putting a seatbelt on. But that is kind of our code word, if you get into that situation, make sure you have your condom on. Not that I'm promoting it or anything, but they're boys and you know how teenagers will be. But I'm just, they know that I'm all about that safe sex thing. And they will always say, yes, mom, seatbelts, right? So that's just my condom story. So get them in the car where they can't jump out and talk to them about it. All right, so they have female condoms, right? These are sheath with a ring at each end. There's a closed ring over the cervix. Open ring stays outside the vagina. One-time use only. They're pre-lubricated, but not with spermicide. And they're not designed to be used with male condoms, so you can't use them at the same time. Disadvantages, they do cost a lot. They're kind of noisy during intercourse, and they're cumbersome. They feel cumbersome. The diaphragm is used with spermicide cream or jelly. Good level of protection against having a baby. It's fitted and instructed by trained personnel. Recheck the size after childbirth and if the woman gains more than 10 pounds. It's inserted before intercourse. Must leave in place for at least 6 hours. Use additional spermicide if intercourse again during that time. Excellent for lactating women, those who can't or don't want to use oral contraceptives, some age smokers over age of 35, or those who have infrequent intercourse. Silicone is available for women with latex allergies. Obese women, those with short fingers may have difficulty inserting it. Not recommended if there's a history of a urinary tract infection or toxic shock. Should not be used during menstrual period if abnormal vaginal discharge is there. All right, cervical cap. This is a silicone cup device used with spermicide, does not have to fit on the cervix. It's held in place by vaginal wall muscles. A vaginal sponge. This is like a pillow-shaped, soft, you can see it right here, absorbent synthetic sponge containing spermicide. Its concave area on one side fits over your cervix. Left in place for 6 hours following intercourse, can be worn up to 24 hours. Some of the advantages, it's over the counter, may be used for multiple acts for up to 24 hours. One size fits all, and it acts as a barrier and a spermicide. Sometimes people have difficulty removing it. Some women report vaginal dryness with it. And the failure rate is higher for women who have had children before. Intrauterine contraception. These are safe, effective, reversible contraceptions. You'll have an intrauterine contraception IUC device. This is inserted into the uterus by a qualified provider, left in place for several years. It does trigger release of body substances that prevent sperm from reaching the ovum. Advantages, it's highly effective and continuous, so you don't have to remember to take it. Relatively inexpensive, and no activity required at the time of intercourse. The disadvantages, it's discomfort at insertion. You may have increased bleeding during your menses, increased risk of pelvic infection after insertion, and intramenstrual bleeding, so you may have some dysmenorrhea. So intermenstrual bleeding, so you're going to bleed possibly when it's not even your menses. Then they also have the Mirena. This is 2 forms of IUC, those intrauterine conceptions. They can be left in place for up to 10 years. They have releasing systems that releases a hormonal hormone. They can be left, they put them in the arm, and they reduce the length amount of bleeding in between menstrual cycles. They're effective against ectopic pregnancies, and they're a good choice for women who cannot use hormonal contraception because they release a non-hormonal intrauterine system. So Mirena, but I don't think you'll see a whole lot about it right now because I think they're having some difficulties with them. The little sticks are moving places, so we're not going to talk about those right now. So we're just going to move on. All right, so hormonal contraceptives. These are combined estrogen and progesterone approaches. They inhibit release of the ovum. They create a trophic endometrium, maintain thick cervical mucus, which slows the sperm and inhibits the process that lets sperm penetrate the ovum. So you can have combined oral contraceptives, which are called COCs, okay? That's a combination, like I said, safe, highly effective, rapidly reversible. You take in for 21 days, off for 7. At approximately the same time every day. Low doses may not completely suppress ovarian function. You can have ovarian follicle, possible ovulation. Some brands of low-dose COCs have shorter or modified intervals. Extended COCs may have a 91-day regimen. You'll have an active pill for 84 days and then an inactive pill, like a sugar pill, for 7 days. Only 4 periods a year, and reduces the side effects of COC. So what are those side effects of combined oral contraceptives? Well, you have aches, serious complications of oral birth controls, abdominal pain, chest pain, shortness of breath, headaches, sudden persistent CVA or increased blood pressure, eye problems. You can have vascular accident or increased blood pressure here too, and severe leg pain, so thrombolytic process. So you need to know aches, and that is your serious side effects of hormonal contraceptive. Absolute contradictions for use of COCs. If you're pregnant, you're not going to be taking your birth control pill, right? And history of DVTs, thrombolysis, you don't want that. Liver disease, estrogen-dependent carcinomas, undiagnosed uterine bleeding. If you're a heavy smoker, you don't need to take you don't need to take this. You probably need another one. Heavy smoking, gallbladder disease, hypertension, diabetes, hyperlipidemia. Okay. Relative contraindications, if you have migraine headaches, if you have epilepsy, depression, oligomenorrhea, or amenorrhea, okay, you don't want those because they'll make it worse. Non-contraceptive benefits of birth control: they can relieve uncomfortable menstrual symptoms sometimes. They can have decreased incidence of functional ovarian cysts. They can reduce the incidence of ectopic pregnancies, ovarian cancer, endometrial cancer, iron deficiency, anemia, benign breast disease. They may relieve symptoms of perimenopause, but you definitely need to contact your healthcare provider if you become depressed, if you become jaundiced, develop a breast lump, or other warning signs such as severe abdominal pain, chest pain, severe headaches, dizziness, blurriness, speech problems, and severe leg pains. Right there, those are all those aches, right? So know your aches. They also have a progesterone only, which is a mini pill. It's for nursing mothers. They can take it, safe for them, not only for them, but they can take it. It's used by women who have contraindication to estrogen component. So sometimes the problems, they can have irregular spotting or bleeding or amenorrhea. Then you have other combined hormonal methods. Who would have known that there's so many things here? You can have a contraceptive skin patch, which is applied weekly for 3 weeks, then no patch during the 4th week. Highly effective in women weighing less than 198. Don't weigh 199. So less than 198. Better compliance rate because you don't have to remember to take it every day, and it's as safe and reliable as your regular contraceptives. Vaginal contraceptive ring, you left in place for 3 weeks, removed for 1. It's highly effective, minimal side effects, can be worn during intercourse, and it's comfortable for a woman and her partner. These are the long-acting progesterone contraceptives that I was telling you about, the little sticks. They're a little rod inserted under the skin. It's effective up to 2 years. Possible side effects: they can have some spotting, irregular bleeding, amenorrhea, increased incidence of ovarian cyst, possible weight gain, headaches, mood changes, and vaginal dryness. Long-acting progesterone contraceptives, the injection, that's the DMPA, highly effective for 3 months with single injection, safe, convenient, private, relatively inexpensive, and it's safe for nursing mothers. Some side effects: you may have some menstrual irregular headache, weight gain, breast tenderness, depression. Return of fertility may be delayed on an average of 10 months. So if you want to get pregnant, it's probably not the thing you want to do. Not recommended for use in longer than 2 years. Low dose form may result in less bone density loss for longer term, and it's administered sub-Q every 10 to 13 weeks. Then we have emergency contraception. It's used in cases of unprotected intercourse, rape, possible contraceptive failure. There's 3 emergency contraception methods. There's the Plan B. This stops or delays ovulation, causes change in the endometrium, thickens the cervical mucus. Then you have ulipristal acetate. That prevents or delays the ovulation, decreases thickening of the endometrium. And then you have a copper IUC, which is placement within 5 days of unprotected sex, may reduce your pregnancy risk. All these are controversial, and women with strong right to live beliefs may decline the use of these. Then we have the vasectomy procedure. This is an operative sterilization surgery that is permanently prevents pregnancy for males. This is male sterilization, vasectomy. It severs the vas deferens in both sides of the scrotum. You can see in this picture. Takes greater than 8 weeks or less than 8 weeks until sperm is cleared. Sorry, it takes more than 8 weeks until sperm is cleared from the vas deferens. Possible side effects, it has pain, there's some swelling, you could have injury to other organs, you could have an infection, hematoma, but sometimes it can be reversed using expensive specialized technique, and it has a 30 to 70% success rate. For women, there's fertile or female sterilization called a tubal ligation. That's where your fallopian tubes are clipped, ligated, or electrically coagulated, banded, or plugged. Okay, so they can have them cauterized, tied and cut, or banded. Complications possible but are uncommon. Reversal is expensive. It's a major surgery. Depends on the type of procedure that was performed. They have an Essure outpatient procedure, no surgical incision. It's a stainless steel micro insert placed in tubes. It stimulates the growth of the local tissue, occluding tubes in 3 to 6 months. And you can have that done too. All right, so clinical interruption of pregnancy, abortion. We're not going to talk a whole lot about this. It was legalized in 1973. It's up to you if you want it. Life-threatening fetal problems can be stress created by timing and circumstances. If you have contraceptive failure, financial considerations, interpersonal violence, sexual assault, incest, it's your right. If you want to do it, it's your right. That's all we got to say about that. Okay. Medical abortion. That is effective alternative to surgical abortion for unintended pregnancy. I'll let you guys kind of read that. Okay. And there's some more on that. In second trimester, a D&E, easier and safer in the first trimester. Nurses may refuse to participate on moral grounds. That's your right. But you are obligated to provide patient safety and avoid patient abandonment. Okay. All right. So you can also have therapeutic donor insemination, therapeutic husband insemination, in vitro fertilization. We're not going to talk about a whole lot of that because that's kind of specialized stuff. Okay. So if you can't have a baby on your own, you can have some fertilization done that way. Okay. Lifespans, education about risk for unprotected sex, help develop attitudes and behaviors that support sexual health in the adolescents. Nurse must address topics of sexual behavior, sexual health in a straightforward, non-judgmental way. You have to be a non-judgmental way. No matter if you believe in abortion or if you don't, you have to be non-judgmental. So if you're totally against abortion, I don't think I would work in an abortion clinic, right? If you're totally for it, I don't think I would work in a clinic that, doesn't offer that option to your patients. So if you go to work in something like that, you have to know you're non-judgmental, right? You have to know thyself. You have to know what your beliefs are. You have to know what you're comfortable doing because you cannot abandon your patient, okay? Encourage your patients to have open dialogue about sex with their parents and their partners. Don't make a big deal about it if you're a parent, if your kid comes and tells you about something somebody else does, because they're going to watch your reaction. Explain circumstances in which details must be disclosed, and provide information about community resources that help safe sex and sex health. Pregnancy. We have to talk about return to fertility after they're pregnant. May occur before the onset of their menstrual cycle. Considerations about postpartum. What are you going to use as a contraception? Okay. Changes in vaginal tone. You got to talk about that. Improper diaphragm fitting. Patients who breastfeed may choose a different type of contraception. Effectiveness varies. A secondary method of contraception should be used probably. And we just talked all about all of those, so you can talk to your patient about all those. All right, and so for those women that are over 35, it is more of a risk to have a baby at that age, just because of the genetics. And, you know, males are born with all their sperm. Women, or males, I'm sorry, males are always developing sperm, and women are born with our eggs. So they can say the time is ticking, or our eggs are getting old or sour or whatever. So it does take longer for a woman in this age group to become pregnant. Highly likelihood of twins, because usually they're going to be using intro vitro fertilization. Babies of women in this group are at risk for chromosomal abnormalities. We talked about that. Risk of pregnancy loss increases with maternal age. Complications, gestational diabetes. They can have hypertension. They're increased risk for cesarean. It also is going to affect the ability to conceive, the development of the fetus, birth defects, and the child's health. All right, moving right along here, guys. So when we're talking to those patients, you know, we need to identify their specific needs. We need to they have options, you know, so they can make informed decisions. Non-judgmental, right? Open communication, reassurance of confidentiality. I'm not going to go tell anybody of this. Let them know there's options for treatment. Choose an option that best fits them. Promote their body health image, right? Provide resources as appropriate. Teach patient the use of the contraceptives, right? Encourage verbalization of their feelings. Encourage to talk to their partner. Encourage patient to discuss terms of sexuality with a therapist if they need to. Teach the patient about the risk factors for reproduction dysfunction, disease prevention, and teach them about the specific disease and prescribed treatment that they're going to get. So we want our patients informed about decisions. We want them to be able to verbalize their understanding and express their feelings openly. If that doesn't work, we definitely need to do referral for treatment in the area of sexual health or infertility. All right, I'm going to take one quick break and I'll be right back. All right, this is a very long chapter. Okay, so menopause. Some women have troublesome health experiences with menopause, as the body's normal physiological process decreases, right? The time which the reproductive function gradually ceases can last several years. The average age is 51 in the United States. Most happen in their 40s, though. Certain risk health increase, so heart disease, osteoporosis, macular degeneration, cognitive changes, and breast cancer. So as your estrogen decreases, various tissues are affected, okay? Your cervix, your vagina becomes smaller, your ovaries, you get vaginal dryness, dyspareunia, urinary stress incontinence, urinary tract infections, vaginitis, and atrophic vaginitis can lead to urogenital infection, ulceration, uncomfortable sexual intercourse. Vasomotor instability, so you get hot flashes, palpitations, dizziness, headaches, insomnia, frequently waking up at night with night sweats, your hormonal changes, irritability, you can be anxiety, you can have some depression, And you can have long-term estrogen deprivation, which is an imbalance in bone remodeling, osteoporosis, which could cause fractures and kyphosis, and increase for cardiovascular disease. Sounds like a fun time, right? So all those things are changing, okay? So we need to focus on the care of our patient. We need to relieve their symptoms, minimize post-menopausal health risk. They need reassurance, education, and support, okay? So some of them will have no symptoms. Some of them will have moderate. We need to help them with all these, right? We need to help them as much as we can. So here's just a funny, the 7 stages of menopause: itchy, bitchy, sweaty, sleepy, bloated, forgetful, and psycho. Okay, just to laugh at it. So diagnostic test, not text, hormone levels that indicate menopause, excuse me, decreased estradiol level, and an increased FSH level, okay? They're not routinely measured, but may be used if the diagnosis is a question. So how do we treat this? So hormonal replacement, it was a treatment of choice before 2002. Now the Women's Health Initiative halted early because of indicated that HRT is an increase for breast cancer, a pulmonary embolism, stroke, congestive heart failure. So there's more recent studies suggest that lower doses of estrogen and progesterone started soon after menopause is safe, relieves symptoms of menopause, and decreases the cardiovascular disease. So most current recommendations right now is HRT is most effective for these symptoms, okay? If vaginal dryness or dyspareunia are only symptoms, low dose of vaginal estrogen is preferred. Increased risk for blood clots in the legs, lungs, but these are rare in this age group. 2 selective estrogen receptor modifiers were approved in 2013. Duvet is to treat hot flashes, reduce bone fractures, and I don't know how to pronounce this one, Osphema, to treat dyspareunia, and may increase risk of endometrial cancer and DVTs, okay? Or also remember, we want all their symptoms to be relieved as much as possible, so we can do an SSRI, which is a selective serotonin reuptake inhibitor, and a serotonin norepinephrine reuptake inhibitor, which helps it's an antidepressant basically that may be as effective in relieving hot flashes and night sweats. And we can do non-pharmacological therapy. We can do massage, meditation, soy. Soy has been helpful. Ginseng. Research is unclear or conflicting on ginseng. Bioidentical hormones, those are not proven safe or effective, but that's out there. Black kush is evidence of effectiveness is lacking on that, but those are some things that patients that have told each other that it helps, so they believe it. Premature ovarian failure, menopause occurring before the age of 40. Average age is 27. That's a low number of follicles. So women does not ovulate each month. Periods are irregular. May experiences menopause symptoms, and is asymptomatic. Women with high FSH levels are the only indicator, okay? Medical menopause results from cancer treatment or chemotherapy that damages the ovaries. Symptoms appear gradually, so you have cessation of your menstruation, and then those vasomotor symptoms occur, maybe permanent or temporary. And then you have surgical menopause, which is caused by a removal of the ovaries, an oophorectomy, alone or in combination with a hysterectomy. Sometimes you'll have to have that for ovarian cancer, non-cancer ovary tumors, ovarian abscess, or endometriosis. This is when the onset is abrupt. Symptoms may be severe. You can treat this with HRT. But patients who want to have children should discuss options before getting rid of your ovaries. If only one ovary is moved, patient may still conceive naturally. So, focusing on that, we want them to minimize them symptoms, right? Reduce their risk for cardiovascular, cancer, and osteoporosis, and educate about necessary lifestyle changes. When we're talking to our patient, we need to know if they have any dyspareunia or changes in arousal. Menstrual history. We need to know their changes in bleeding patterns. How long did it last? How regular is it? Any gynecological surgeries, childbirth, past pregnancies. Talk to them about urinary problems, any sleep pattern problems, vasomotor symptoms, changes in emotional responses. Are they drinking? Are they smoking? Are they using drugs? How's their diet? How's their supplement use? Are they taking all those over-the-counter drugs or vitamins? Exercise, what are they getting? Then just with your physical assessment, make sure you get their vitals, their height and weight and posture, their breast exam. Is it irregular? Changes in any shape, skin and nipple appearance, masses in breast tissue or swelling in lymph nodes. And then do your abdominal assessment, percussion and palpation, pelvic exam. You want to know what the appearance of the external genitalia is, the vagina and the cervix, and collect any necessary samples while you're doing that. Okay, so remember, our goal is to understand their process, to reduce and cope with symptoms, and a program probably of weight-bearing exercises because of their chances of osteoporosis. Discuss their manifestations with them, you know, talk about the risk and benefits of their hormone replacement therapy, encourage them to talk about their feelings and concerns, talk to them about how it may change their their sex life, right? Explain that the vaginal lubrication, and it may take longer. Offer referrals, dietary, stress, cosmetic, you know, and that's it on menopause. All right, let's talk really quick, hopefully, on menstrual dysfunctions. I don't think this section is as long. Menstrual dysfunction. So normal menses involves minor discomfort. You'll have breast tenderness, cramping, low back pain. You can have some mood swings. Some women experience more serious menstrual dysfunctions with pain, excessive bleeding, or both. Okay. There's two categories of menstrual dysfunction. Dysmenorrhea, that's pain associated with menses, one of the most common menstrual dysfunctions. Or you can have dysfunctional uterine bleeding, also known as DUB, which is heavy uterine bleeding that is irregular but painless. So let's talk about dysmenorrhea. This is hormonal, common in young women with normal menstrual function. Some of the symptoms you'll see is pelvic pain that radiates to the groin, low back pain lasting 12 to 48 hours, pain radiating to lower back and the thighs, diarrhea, headache, nausea, vomiting, anorexia, breast tenderness. Just pain begins on the first day of the menses or 3 to 5 days before. Typically peaks 24 hours after menses begins and decreases in 2 to 3 days. So it's caused by the release of those prostaglandins, which cause uterine contractions to expel menstrual fluid and tissue. Other inflammatory mediators may prolong contractions and decrease blood flow. So this is very painful. Primary dysmenorrhea is what we were talking about, okay? Headache, nausea, vomiting, anorexia, all those things I just said. So that's your primary. Typically begins within 6 months of their menses. including cramping, steady lower abdominal pain, radiating to the back or down their thighs. Okay, so these are things you probably should know about primary. And hold on, I have a wasp flying over my head. Okay, didn't get the wasp, I don't know where he is. So if I scream, you know why I'm screaming. Okay, so secondary is related to pathology of diseases of the uterus or the pelvic area, okay? Most likely in women ages 30 to 50, pain may occur at any time in the menstrual cycle, can be severe, dull lower abdominal pain radiating to the back and down the thighs, may begin early in the menstrual cycle and last longer than the primary dysmenorrhea pain, okay? And it can be caused by tumors, cysts, pelvic adhesions, pelvic inflammatory disease, cervical stenosis, and it goes on and on there. It's pain that begins immediately, okay? Pain from endometriosis may worsen each month, may be complicated, begins a few days, onset of menses becomes much worse, may be constant if endometriosis is long lasting. So endometriosis is the most common cause of secondary dysmenorrhea. Cells from the endometrial tissue implant and grow outside the uterus, responding to estrogen and progesterone. The mature open and bleed each month, causing pain, fibrosis, and adhesions. May occur anywhere in the body, usually on organs in the lower pelvis. And then DUB involves little or no pain. It's profuse, painless bleeding preceded by long stretches of amenorrhea. Cycles produce thickened endometrial lining that begins irregular sloughing, prolonged heavy bleeding. All right. Some clinical manifestations, like I just said, one or several patterns. These are all different types of bleeding, right? And you can read all those, okay? All right, so some diagnostic testing that we're gonna do for them. We can do a Pap test. We can cervical cultures, ultrasounds, hysteroscopy, infusion, saline infusion, sonohistograph, colposcopy, endometrial biopsy, endocervical cartilage and biopsy, CT scan and MRI, laparoscopy. They can do a pregnancy test, that FSH and LH hormones, progesterone levels, thyroid levels, CBC, and coagulation studies. Okay, so let's talk about who's at risk for this. Okay, so who is at risk for having all these? For dysmenorrhea, your early age of menarche, so you're at risk. Longer or heavy menstrual periods, smoking, and a family history. Who's at risk for endometriosis? When your menses starts before the age of 11, your cycle is longer than 27 days, you have heavy or prolonged menses, sedentary lifestyle, increased dietary fat, and first degree relative with endometriosis. For the DUB, usually it's teens earlier in their 20s, approaching menopause are at risk. Stress, extreme weight changes, obesity, thyroid disease, metabolic disorders, use of hormone replacement therapy, and use of intrauterine contraception, those IUC devices we talked about. Okay, so there's surgery. We can do a DNC. Cervical canal dilated, uterine wall is scraped. This is just kind of explaining how we can care for those patients. These are different things that we can do. Endometrial ablation, this destroys the uterine lining, uses extreme cold, heated fluids, microwave energy, or radio frequency waves. Not recommended for women who want to become pregnant. Not recommended as a primary therapy either. You can have a hysterectomy, removal of your uterus. You can have abdominal hysterectomy, vaginal hysterectomy, laparoscopic assisted vaginal hysterectomy is the most often performed. Okay. So there's your partial, your total, your radical. Okay. It's telling you what parts are being removed. Pharmacological therapy that we do is heavy reliance on hormonal therapies for severe and incapacitating symptoms of dysmenorrhea. So they'll do a combined COC, Depo, Danazol, or a GnRH agnostic to suppress that ovulation happening. COCs and progesterone injections to relieve cramping, NSAIDs to relieve cramping, SSRIs to manage mood and help the patient cope with the chronic pain, and diuretics to relieve bloating. To correct menstrual irregularities, COCs can be used, Depo-Provera to regulate uterine bleeding, those IUCs to control bleeding, conjugated estrogens, and med-oxyprogesterone for heavy bleeding. Oral iron supplements can replace the iron lost through bleeding too. But if they're taking oral iron supplements, you also need to tell them to drink lots of water because then they can become constipated. Lifespans, cyclic changes in estrogen and progesterone become irregular, release of additional prostaglandins stimulate uterine contractions, can cause primary amenorrhea, changes in perimenopausal menstrual bleeding. You can have heavy bleeding, longer menstruation, more frequent menstruation. In menopause, pain associated with dysmenorrhea stops and the DUB stops. Other conditions may cause bleeding similar to the DUB, and patients may seek medical attention for any postmenopausal bleeding. Cyclic changes in estrogen and progesterone become irregular. Release of additional prostaglandins stimulate uterine contractions, so it can cause primary amenorrhea, changes in perimenopausal menstrual bleeding, heavy bleeding, longer menstruation, and more frequent menstruation. So we need to talk to them about the physiologic of their menstrual cycle, trying to control their manifestations and self-care according to their underlying cause. So during our assessment, we need to know their last menstrual period, the typical length of their cycle, their last OBGYN appointment. We need to know their menstrual history, past pregnancies, any childbirth, gynecological surgeries, their typical sexual practices, and the last date of sexual intercourse. They need to know if they're on birth control or any medications, and if they have any pre-existing conditions. During their physical exam, vital signs, percuss, then palpate the abdomen, examine the genitals, samples for their pap tests, blood for hemoglobin, and hematocrit because they're bleeding a lot, right? Planning, we want to reduce their pain and discomfort. We want them to experience physical comfort. We want them to increase intake of fluids and iron-rich foods, become more comfortable discussing menstruation, identifying coping strategies to reduce anxiety, and maintain journal of their symptoms, and talk about their sexual dysfunction. If they're bleeding all the time, they're probably not enjoying sexual relations, right? Teach them pharmacological and non-pharmacological self-care methods. So exercise, relaxation, heat, okay? Relieve their anxiety, Evaluate coping strategies. Review how fatigue may be affecting women's activities of daily living, and suggest ways to balance activity. Promote some sexual function, talk to them about sexual activity during menstruation, encourage frequent rest periods, provide information of alternative methods of sexual expression for them. Okay, let's get on to sexual dysfunction. All right, so male sexual dysfunction is going to be 4 types. So we have male hypoactive sexual desire disorder. Sorry, there was a guy driving down my street on a lawnmower. Okay, so we have male hyperactivity sexual desire disorder. We have erectile dysfunction, which erectile dysfunction is going to be the most common one that you've heard of. Then we have premature ejaculation and delayed ejaculation, okay? So different causes and manifestations all have dramatic negative effects on the man's ability to enjoy sex. So what are some symptoms? Well, first of all, least common male sexual dysfunction is that male hypoactive sexual disorder desire. This is many men experience problems that don't satisfy the 6-month requirement. Prevalence of milder desire problems increases with age. So you have to have deficient or absent sexual thoughts or desires for greater than 75% of the time for greater than 6 months. Lack of desire is a source of significant distress to the patient, okay? And lack of desire not related to any other medical problems, okay? So that's what you have to be diagnosed with that. And the desire discrepancy between man and his partner is not enough. So that would mean like the woman says, he never wants to have sex with me. You just can't go in and say that. Okay, so ED. Oh, dear old Ed here. Erectile dysfunction. That's the inability of a male to obtain or maintain an erection sufficient for intercourse. May involve total or inconsistent inability to achieve an erection or ability to sustain erection only briefly. The penis may become semi-erect but lacks significant rigidity for intercourse. Also known as impotence, but that's an outdated term. Erectile disorder, preferred term for ED, unrelated to physical causes. Characteristics of this is as a disorder of arousal, may or may not be associated with loss of libido, occurs in men of all ages, and can be chronic, intermittent, or episodic. So the incidence, it's difficult to estimate because many men are not going to report this. Most of the men that are reporting it is because the wife is telling the man, you better get in and get something done about it, right? Different view on how long the disorder must be persistent to be diagnosed. 52% of men report at least occasional erectile dysfunctions, difficulties. Older men are affected at higher rates, and rates of chronic or complete ED lower than those for an occasional ED. Okay, so there's just a little slide there that talks about it. So, erection is a neurovascular event requiring functional, autonomic, and somatic nerves, smooth and striated muscles, and adequate arterial blood flow. Okay, so it occurs when the chambers of the erectile tissue of the penis are filled with blood. Pelvic muscle contractions help increase the penile rigidity, and then the veins in the penis constrict. They block blood outflow until orgasm or removal of the sexual stimulation. Causes: vascular, neurological, urological, endocrine, respiratory, iatrogenic, lifestyle related, or they can be psychological, or the aging process. In the aging process, you have less elastic collagen in the penis, interferes with the veno-occlusive mechanism, declining ability of the skin to sense vibrotactile stimulation. Hypogonadism is decreased testosterone, and likelihood of chronic conditions that are linked to ED. Prevention. How do we prevent Ed coming and visiting? Mitigation of general risk factors. You have to have some regular exercise, a balanced diet, healthy body weight, no tobacco, no alcohol, right? Mitigation of risk factors to particular patients. Men with diabetes need to maintain appropriate blood levels. Men with depression need to seek some counseling. Many medications are used to treat problems related to ED and can themselves produce erectile problems as a side effect. So you're taking the medicine and it's giving you the side effect that you're taking it for. All right, so let's go to delayed ejaculation. This is extreme difficulty ejaculating despite ability to maintain an erection for long periods. So they can have an erection, they just can't have ejaculation. Rare, occurs mostly after, did I miss one? No, okay. So it occurs mostly after age 50. Diagnosed when the man reports marked delay, infrequency, or absence of ejaculation at all or most partner sexual encounters for greater than 6 months. Distinct from retrograde ejaculation, and that's ejaculation that occurs but the fluid travels to the bladder. The causes, primary delayed ejaculation is usually psychologic, okay? Secondary delayed ejaculation is usually by certain meds, various diseases, injuries that affect nerve function in the pelvis. Okay. Sorry. And then let's talk really quick about premature ejaculation. That is, man consistently ejaculates before or shortly after penetration. Practitioners hesitate to diagnose this unless symptoms are persistent for 6 months. Common as an isolated event, only 1 to 3% of men have chronic premature ejaculations. Some men may experience it in all situations. Others experience it only with certain partners or certain types of activities. Most common its occurrence in the younger men and most likely to be chronic in older men. It can be biological or psychological, often related to psychological issues or events of childhood or adolescence. Men with depression, anxiety disorders are most likely to be affected. Or some men that have opioid use, nerve damage, thyroid dysfunction, prostate disease, or urethral infection. All right, now let's get to women. They have 3 types of sexual dysfunctions. There's female sexual interest arousal disorder, female orgasmic disorder, and the genitopelvic pain penetration disorder. Okay, say those things fast 3 times. All right, so the most common sexual complaints in women is low or absent desire for sex, difficulties attaining adequate levels of arousal. How do you get diagnosed? You have to have decreased or absent sexual thoughts, interest in sexual activity, mental feelings of arousal or pleasurable sensations for 75% of the time for greater than 6 months. Significant distress as a result, and more than a discrepancy in desire between women and partner. How often is it happening? This is the most common sexual dysfunction. At all ages are affected, but most often it's reported mostly by middle age. Older women may be affected but less troubled by it or less likely to report. So let's go back to this one here real quick. So patho-wise, it may be involve physical or psychological. So aging, medical conditions like endometriosis and cancer, side effects of medications, psychological factors Schizophrenia, anxiety, depression, PTSD can have this problem. Sexual abuse in the childhood, alterations in their body image, and their cultural and religious attitudes towards sex. Remember, I said that was going to play a big thing in their ability. All right, female orgasmic disorder. This is persistent delay or absence of orgasm following normal sexual excitement. 75% of the time for greater than 6 months, has to have distress, and may be diagnosed when women persistently experiences orgasms of very low intensity. Second most common female sexual dysfunction, some as high as 40%, but most likely it's 16 to 8 or 28% of patients are complaining of this. And up to 10% of women have never experienced an orgasm. So maybe lifelong or acquired, generalized, or situational. What causes this? Lack of sexual experimentation, self-exploration, and education. It can have physical factors, genetic influences, may involve disruptions in sympathetic, parasympathetic nervous functions. Diseases or health conditions may impair it. Gynecological surgeries can have that problem. Alcohol-related drugs and medications. Psychological contributors similar to those of all the other sexual dysfunctions, relationship problems, and then cultural and religious influences. Then we have genitopelvic pain penetration disorder. This is persistent or reoccurring dyspareunia or fear of pain before or during vaginal penetration. Okay, may involve vaginismus, involuntary tightening of those pelvic muscles, preventing penetration. It has to be greater than 75% or 6 months. For 6 months, that should be, you should know that by now, right? Everything is over 75% for 6 months, and it has to have significant distress. May involve the entire vulva or only a portion of it, and it may involve all situations involving penetration or only occur in specific scenarios. So sexual intercourse, but not gynecological exams, or gynecological exams may be painful, but not sexual intercourse, okay? Usually it's an acquired condition, inadequate lubrication, inflammatory or abnormalities of the vulva or reproductive tract, declines in estrogen, irritation caused by contraceptive foams, cream, sponge, or latex. Deep dyspareunia, often linked to pelvic disease or abnormality. Primary vaginismus is malformations of the genital tract, hypertonicity, or poor control of pelvic muscles. Psychological causes may be linked to sexual trauma, relationship difficulties, painful or traumatic childbirth, presence of other sexual dysfunctions, anxiety and fear, high levels of it. Fear and sexual pain often have cyclic relationships. Okay, so women who grew up in a sexually repressive environment are at increased risk. Condition more common in societies where women have few sexual rights are subject to practice such as forced marriage, child marriage, and polygamy. All right, male sexual dysfunction. Treat starts with least invasive method. They have to have lifestyle changes. Patient history and physical exam. You're going to ask them. Medical team checks for related health problems, medication assessment, diagnostic tests for them you can do as part of a follow-up. You can have a CBC, you can have a urinalysis, lipid profile, kidney level function, testosterone levels, PSA levels, and for ED, you have nocturnal penile and rigidity monitoring, tumor and rigidity monitoring. Pharmacological, And pharmacological treatments for male dysfunctions, they can have oral stimulations, orals, injections. They can have hormonal replacement. They can have injectables, and we'll talk about that. Medications, they have gels and everything. So side effects can be weight gain, hyperglycemia, priapism, renal stones, and jaundice. So for erectile dysfunction, you can have Viagra, Levitra, Cialis. Those are just a few to name. You can have an injection into the penis to stimulate it, or an insertion into the urethra. Difficult to administer sometimes, but used to patients who cannot take oral drugs. Pharmacological therapy for patients with ejaculation problems, difficulties, premature ejaculation. You can do Emla cream. So it's not reliable medications, but it can help. It doesn't give the penis the pleasurable feelings right away because it's lidocaine. Okay, antidepressants and topical anesthetics may be useful. So you're just kind of numbing the area. Non-pharmacological therapy is surgery limited to treatment of ED, reserved for cases in which all other interventions fail. So you have to do everything else first before you go for surgery. You'll have revascularization procedures. Generally, they're unsuccessful, and results are often temporary. So non-pharmacological therapies. You can have implantation of prosthetic devices. They can have malleable rods placed in the corpo cavernosa, inflatable implants that fill with the water via the pump. On man generally satisfied with the prosthetic, but he is at increase for infection. So there's just a couple different therapies that they can do. You can also have assistive devices, vacuum constrictive device. So for the penile or the delayed ejaculation, they'll do a penile vibratory stimulation. Premature ejaculation, they can use condoms to reduce genital sensation. And counseling and other behavioral therapies have been useful. Now with the female, we definitely need to get her patient history, degree of the problem, diseases, lifestyle habits, prior events, any meds that may contribute. Do a focused pelvic exam. Women who have dyspareunia might not tolerate the speculum or more than one finger during the pelvic exam, so be careful. Lab tests, we can do lab tests to confirm out and rule out other conditions. So those are all some of the lab tests we can do. Sorry, those are all some of the lab tests we can do. Hormone replacement therapy we can do, most common treatment for patients with low desire or low arousal or sexual pain. We can do estrogen replacement, increases the genital sensitivity and lubrication, reverses vulval and vaginal atrophy, relieve dyspareunia, may be administered with progesterone in women with the uterus to reduce risk for heart attack and dementia and breast cancer and any DVTs, but short-term use is recommended. So here's some of the treatments, the HRTs, okay? They mimic the action of the estrogen. Testosterone for female use may be prescribed off-label. And this is an antidepressant with desire-increasing effects. Bupropion and filabanserin is the only FDA-approved drug for treatment of low desire in women. High costs, low effectiveness, potentially dangerous interactions. So I don't think I'd want that. And here's some non-pharmacological therapies, assisted devices, so vibrators, clitoral vacuum devices, lubricants, vaginal moisturizers, vaginal dilators, in counseling and therapy. Lifespan considerations, pregnant and postpartum women, we have to look out for changes of pregnancy and childbirth may cause some sexual dysfunction. During pregnancy often fluctuates by the trimester. Difficulties most common in third trimester. Changes in their body sizes and mechanics. Fear that penetration may harm the fetus. Sexual dysfunction may worsen after childbirth. Decreased androgen estrogen levels. Delivery related damage to any of the area down the vulva, the perineum, pelvic floor. Fatigue, right? Little research, a nurse may suggest experimenting with positions and alternative activities. Older adults, sexual dysfunction increases, right? We've already learned that. Coincides with women with premenopause, perimenopause. For men, it coincides with male climatic, right? They take longer. Hormones are not solely responsible. It may be linked to various psychological and physical, chronic disease, medication use, role changes, grief, fear of death, physical decline, often reluctant to discuss with the healthcare providers. So nurses should assure a patient that interest in sex is normal for older ages. All right, moving right along. This is our last one, I think. Sexually transmitted infections. So infections are transmitted by vaginal, oral, anal, intimate contact caused by bacteria, viruses, fungi, protozoa, and parasites. Portals of entry include mouth, genitalia, urinary meatus, anus, rectum, and skin. Most can be prevented by using a latex condom. Put on your seatbelts, right? Sexually transmitted diseases, STDs, typically caused by a virus. These terms STI and STD are often used interchangeable. Bacterial STIs can be cured by early treatment with antibiotics. Viral STIs can be managed but not cured. You need to know that. Bacterial STIs can be cured by early treatment with antibiotics. Viral STIs can be managed but not cured. AIDS is the most serious. The epidemics are proportionate worldwide. They affect men and women of all ages, backgrounds, and socioeconomic levels. Women usually have a higher rate of gonorrhea. Men have higher rates of chlamydia and syphilis. So risk factors, multiple sex partners or a new partner, sex with someone who has sex with one or more others, exchange of sex for money or drugs, poverty, unemployment, and low educational level. Women, usually young women under the age of 25, drug or alcohol use that lowers inhibitions and presence of another STI. So prevention and control, wear your seatbelt, right? Education, detection, effective diagnosis, treatment. We need to get them in, we need to get them checked, we need to get their partners checked. You need to get an ability to get an accurate history. Both partners need to be tested and treated, okay? Both partners and get treated. Okay, so HPV is human papillomavirus, is the most common, about 40 types that can affect genitals. Genital warts are painless, soft, flesh-colored, raised or flat, large or small. The vulval vaginal area, perineum, penis, urethra, anus, groin, or thigh. Causative agents in many genital cancers, okay? Most sexually active individuals will get at least one type of HPV in their lives. Women are at greater risk because there's a larger mucosal surface area exposed in the genital area. 90% of cases clear with no intervention within 2 years. And if you have persistent HPV genital warts, you are at greater risk for cervical cancer. Less often is vulvar, penile, anal, or oropharyngeal cancer. It's transmitted by vaginal, anal, oral, genital contact. Incubation period is 3 weeks to 3 months. What you'll see is some individuals with HPV have no symptoms. Others will have genital warts, and the diagnosis is made on basis of clinical appearance. There is no cure for HPV. Genital warts can be removed with treatment. Healthcare providers may freeze or burn them off. Patients may use different treatments at home, and extensive warts may require CO2 laser removal. There's some pictures of the genital warts. Genital herpes is a simplex virus, HSV-1 and HSV-2. HSV-1 is associated with cold sores, but may be transmitted to genitals by oral intercourse, by poor hand hygiene, and self-inoculation. So if you are having oral sex with somebody that has a cold sore, yes, it can be transmitted. HSV-2 is transmitted by sexual activity or during childbirth from an infected woman. Causes genital herpes, most common in young sexual active adults. Associated with the early onset of sexual activity, multiple sex partners, there's no cure, but antivirals lessen the severity of the outbreak and shorten its duration. With this genital herpes, you'll see small painful vesicles in the genital area 2 to 12 days after exposure. The man, you'll see on the glands of the shaft or penis. In the women, it'll be on the labia, the perineum, the vagina, or cervix. In or around the anus from anal intercourse or oral anal sexual contact. Blisters will break. They shed highly infectious virus, create patches of painful ulcers lasting 2 to 4 weeks. Touching the blisters, then rubbing or scratching anywhere on your other parts of your body can make it spread. They will have flu-like symptoms, dysuria, vaginal discharge for women. Men will have urinary discharge. Subsequent occurrences are usually less severe, shorter in duration, and number of outbreaks decreases over time. That viral shedding can occur between outbreaks. Prodromal symptoms of recurrent outbreaks will be burning, itching, tingling, or throbbing where the lesions commonly appear. You'll have pain in legs, groin, or buttocks, and sexual contact should be avoided when prodromal symptoms are present. Treatments for this is to relieve the symptoms because it cannot be cured. So we're going to prevent the spread of infection. Antiviral medications reduce the length and severity. Acyclovir is usually the treatment of choice. Patient education is essential to prevent the spread of the disease and to help manage chronic disease. Now we'll talk about chlamydia, caused by Chlamydia trachomatis. Bacterium that behaves like a virus. It reproduces only within host cells. This is spread by sexual contact and to neonate in birth canal of infected mother. It can include acute urethral syndrome, non-congenital urethritis, mucopurulent cervicitis, and pelvic inflammatory disease. Most commonly reported bacteria STI in the United States. 2/3 of new infections occur in 15 to 24-year-olds because they're not wearing their seatbelts, right? Risk factors: being sexually active, being a female, being between ages of 14 and 19, personal history of STI or a partner with such history, cervical ectopy, multiple sex partners, unprotected sex, drug or alcohol use that increases risky sexual behavior. Some will have asymptomatic in most women until the uterus and the fallopian tubes have been invaded. Treatment may be delayed, which causes long-term complications. So if you wanted to have a baby, this could prevent infertility. You could have ectopic pregnancies. Infants born to untreated mothers are at risk for chlamydial conjunctivitis and pneumonia. Treatment: untreated chlamydial infection in women may ascend to upper respiratory tracts. Complications include pelvic inflammatory disease, possible with endometriitis, salpingitis, chronic pelvic pain, scarring of your fallopian tubes. So you can have asymptomatic in 90% of men. Most common complication is reactive arthritis. Other complications are epididymitis, prostatitis, and sterility. So the Centers for Disease and Control and Prevention recommends routine screening for sexually active women under the age of 25. Antibiotics are for men and non-pregnant women. Both sex partners must be treated at the same time before resuming sexual intercourse. If you don't get anything out of this, both sex partners need to be treated at the same time before they can have sex again. All right, gonorrhea, caused by Neisseria gonorrhea. Second most common reportable communicable disease in the United States. Risk factors are residents in larger urban areas, being transient, early sexual activity, multiple serial or consecutive sex partners, drug use, prostitution, and previous gonorrheal infection or concurrent STI. Pyogenic bacteria that causes inflammation. Humans are the only host for this organism. Transmitted by sexual intercourse during delivery through infected birth canal. So the portal of entry can be the GI tract, the eyes, the oropharynx, the anorectum, skin. Incubation period is 1 to 14 days in men and 10 days in women. Males usually targets the urethra, acute painful inflammation of the prostate, the epididymis, the periurethral glands, and can lead to sterility. Females initially targets the cervix. You'll have pelvic inflammatory disease, endometriosis, salpingitis, and pelvic peritonitis. May be asymptomatic until the disease is advanced. Men, sometimes you'll see dysuria, serious milky or purulent penile discharge, may have regional lymphadenopathy. Women will have dysuria, urinary frequency, abnormal menses, increased vaginal discharge, and dyspareunia. You can have anorectal gonorrhea, which will have pruritus, mucopurulent discharge, bleeding, pain. Sometimes you'll see gonococcal pharyngitis, which will cause a fever, a sore throat, and an enlarged lymph glands. Men, complications, we went through all these. It's just a different way. But at least in both sexes, you're going to have blindness. You can have blindness, infection of blood and joints, and increased susceptibility to transmission. You're at increased risk of getting transmission of HIV. I don't know why I can't say that today. Gonorrhea treatment: single dose of 6-triaxone and single dose of azithromycin administered at the same time if possible. It will eradicate the organism, prevent reinfection or transmission of other STIs. You have to tell them to emphasize the importance of abstaining from sexual contact until both partners are cured. Condom use to prevent further infections, and especially for pregnant women whose partners may be infected. Syphilis, complex systemic STI caused by Treponemium pallidum, can infect almost any body or tissue, and organ, transmitted from open lesions during any sexual contact. Incubation is 12 to 90 days, averaging 21 days. So if untreated, will progress into 4 stages. Highly contagious in primary, secondary stages, even if asymptomatic. Can lead to blindness, paralysis, mental illness, cardiovascular damage, and may occur with 1 or more STIs. So primary, those are open lesions, appears at the site 3 to 4 weeks after infectious contact. may go unnoticed, disappearing within 3 to 6 weeks. Regional lymph node enlargement, little or no pain. Secondary syphilis, that goes systemic, spreading to all major organs. Manifestations appear several weeks after initial lesions disappear. Rash, especially on the palms of hands or soles of feet. Mucus patches in oral cavity, sore throat, generalized lymphadenopathy, condylomata, flu-like symptoms, and alopecia. Latent syphilis is the period after the secondary lesions resolve. Usually there's no symptoms. Sexual transmission of disease is possible in the early stage, may last 1 year to a lifetime. And tertiary syphilis is 15% of untreated individuals progress to this stage. There's 2 types. Benign late is rapid onset of localized infiltrating tumors in the bones, in the liver, and the skin. Respond promptly to treatment. And diffuse inflammatory response. Insidious onset involving cardiovascular symptoms. Complex diagnosis because it mimics others' diseases. You have to have a careful history and physical exam. Definitive method of diagnosis. Dark field microscopy examination for the lesion for T. pallidum. Requires immediate examination by a trained, experienced technician, and most diagnoses made using blood test. Treatment, inactivate the spirochete, educate patient for prevention of reinfection, antibiotic, identification for partners, follow-up testing, education about wearing their seatbelt. Maternal, pregnant women should be routinely tested, may be repeated during 3rd trimester if patient is at high risk. For mothers, usually occurs during pregnancy for complications. For child, may often occur after birth. Some may not become evident for several months. Varies according to the STI. Antibiotics for bacterial STIs are safe during pregnancies. Antivirals for viral STIs can reduce the passing infection to the child. Children may result of perinatal acquired infections that can persist 2 to 3 years. STIs in children greater than 10 should be considered evidence of less than 10 should be considered evidence of sexual abuse. STI testing should be done before initiating treatment. Examine the child, collect the specimens in a way that minimizes trauma to the child. They usually have people that do this, that are specifically trained for this. Repeat exam and testing may be indicated. The testing and the specimen collection should be done by a clinician with experience in child abuse. Treatment based on the test results. Presumptive treatment not recommended. So amount of time elapsed between the abuse and the initial exam, results of testing, and type of treatment for children. We have a place here in Peoria that does this for sexual abuse children, and they're all specialized in this. Adolescents are high risk for STIs, especially girls. May be very concerned about confidentiality. Sexual health more vulnerable in adolescents, subject to poverty, unemployment, low education. Development, appropriate discussions of sexual behavior, infection risks, safe sex practices, screening for hepatitis A, B, and C, non-judgmental through counseling and care. Older adults, remember I said in the nursing home, grandma and grandpa, increasing HIV, gonorrhea, chlamydia, and STIs. Healthcare providers might not think the older patients are active. They're having their fun, right? May not assess for STIs or provide education about safe sex, so we need to get them in there for safe sex education. And delay diagnosis of disease such as HIV that mimic other diseases. Risk factors, less estrogen, vaginal lining more prone to damage during intercourse. Use of those ED drugs may lead men to engage in more riskier behaviors. Immune system may be less able to fight infection in the older adults. Important to educate about safer sex practices with new partners. Older adults may not believe that they're at risk, and acknowledge that sexual activity is normal in older adults. Whew, we made it. Okay. So if you have any questions, you let me know, and I don't care what they're about, because this was a strange lecture, right? So if there's any questions you have on anything of this, don't hesitate, reach out to me. I'll answer them non-judgmentally, I promise. And I try to let you know the main things that you're going to need to know for a test, but you definitely want to teach them safer sex practices, what their body is doing, and it's not them, that's causing this problem. You definitely want to make sure that you educate them about treatment and medications and side effects, okay? All right. I will see you guys on Wednesday, and if you have questions, you can ask. If not, Wednesday, I think will be a short day because we only have to do a few things on the family. And then you guys are almost done. Almost done. So, all right. Let me know if you have any questions.